2, 1. Welcome, everybody. Happy Friday. We are here today with Dr. Dipesh Sitaram. Thank you so much for being here, Dr. Dipesh.
You're welcome.
I'm going to start by giving Dr. Dipesh's bio to you guys. So, Dr. Dipesh Sitaram approaches everything he does with a passion for doing it well. After earning his dental degree from Indiana University, Dr. Sitaram immediately opened a private dental practice in Indianapolis that grew quickly. He later opened Dental Solutions of Columbus, a second highly successful practice that Dr. Sitaram has since expanded to include a neural surgery and implant center within that office. Dental Solutions is a place where anyone can come and there will be a solution for their dental needs. And not just any solution, but superb personalized treatments performed by great people using state-of-the-art technology. Tell us a little bit more about yourself.
Yeah, obviously I do a lot, everything TMJ, airway, and oral surgery in the realm of TMJ and TMD treatments. The entire scope of non-surgical treatments, and then a full spectrum of surgical treatments. So the whole practice for me revolves around, TMJ related stuff, preventing TMJ. That's intertwined with airway, and then obviously, the oral surgery component of the practice. And that's kind of my passion.
That is amazing. We are so excited to have you here today. And guys, I just want to let everyone know to post your question in the comments whenever you have a question for Dr. Dipesh. I also would like you to type, let's type palatal expansion or TMJ. You can type that on the comments so we know that you're here live and listening to us. If there's any issues with the audio, please let us know and we'll try to fix that for you guys if there's any feedback. But we're going to start. We have an awesome topic today, which is appliances. I am going to sneeze. Excuse me. I've been holding since we started. Okay. Appliances for palatal expansion. There's so much out there, but we are going to start by just talking a little bit. Our ancestors had room for all of their teeth in their mouths. They ate a hard food diet. They breathed through their nose. They breastfed until 3 years old or so. In your opinion, what has made the biggest impact in craniofacial growth in the last 100 years?
What I think humans have gotten smaller in general, and the reason for that, yes, is diet, industrialized countries and things like that. So the food obviously has gotten significantly not only softer, but it's more processed, genetically modified. And the reasons for that are, the population's more, so, we have to be able to grow more food to sustain a larger population as were before. So I get it. Now, the downsides that come with that is there's not a significant amount of stimulation for the growth and development of the jaws, right? So just like with everything else, we work out to build greater muscles, biceps, whatever. Same thing with the growth and development of the jaws. We need, harder, stickier, chewier foods to gain a larger, a larger jaw size to allow for all 32 teeth to fit in. The absolute only reason that wisdom teeth are a thing is because as humans have evolutionarily gotten smaller, there's just no space. And in my opinion, hundreds of years from now, instead of 4 teeth considered wisdom teeth, there are probably going to be 8 teeth, because I don't see this thing changing anytime soon. Yeah, we're trying to make progress, but there's a very small group of us trying to make change at this point, right? Wow. And the population, in my opinion, is only going to continue getting bigger. So the mass production of food, is still going to be there.
Definitely, it is needed in some areas. We're running out of everything, and it's funny. I remember when I was a kid, when we first saw, the what an ET looked like, extraterrestrial, and it was this being with a
Right.
very tiny little jaw and a huge brain. And
Yeah.
we, and people would say, "Oh, we're gonna start looking more and more like that," and I didn't understand until now.
Right. And recently, I watched the movie Seaspiracy and then Beefspiracy.
I do too.
It's mind-boggling, what's going to happen in the future, for our kids and their kids and things like that. I don't know.
It is
Uh,
scary because
it's,
even what's healthy now, it's
right.
not as healthy and it's not good for the world. So it's
Right.
so
Right. So,
difficult.
watching those movies, I learned that the logo on the containers, whatever, what is it called, GMO Project or whatever, is
Hmm.
really you pay a subscription to an organization, and they're all bought out individuals. It doesn't even mean anything.
It is
Uh,
so scary.
so now, I mean, honestly, we don't know what we're taking in nowadays.
No
But
wonder that back in the day they used to live such a healthier life and they used to live longer, but just without all these chronic diseases that we see so early now.
right, and
Um,
now look at the cancer situation, right? It's not a matter of if, it's a matter of when.
yes. Somebody was saying
Everybody.
the other day that cancer is a side effect.
Right. It's a side effect. Right. It's literally becoming a side effect.
Oh my goodness,
Right. So,
it is so scary. But as a
it's
parent, we are so limited by what our dentist recommends as far as a referral to an orthodontist. So, when should parents first seek out a consult? And what are the negative consequences of waiting too long?
I think so. This is a great realm for dental hygienists because if through the education of hygiene with combined with myofunctional therapy, if we can get these kids on the right track early on, it can prevent a lot of things kind of down the road, right? What do I mean by that, right? So as hygienists are, seeing kids in the chair, checking tonsils adenoids, checking breathing patterns, checking postural patterns, right? And then from there, doing one, what they're comfortable with, and then two, if tonsils adenoids require ENT referral, do it. If it requires, evaluation of tongue or tongue posture, things like that, do it. Why? Because if we can get the tongue in the right spot early on, can you imagine how much that will save on the back end of things in terms of expansion, right? Because our natural God-given dental expander is the tongue, right? And the tongue is 100% muscle. The problem is applesauce and cheese whiz and all the other yogurt and froyo you can pretty much shove down their nose and not really even have to go forward on it. So none of that develops tonus of the tongue muscle, right? In virtue of developing tonus of the tongue muscle, then we start getting natural expansion and things like that happening. Now, if all of that fails, then the children still should be evaluated age 6, 7, kind of in that time frame on it.
That's
Uh, and then the other thing is, the more and more, I'm learning and looking at sugar content of foods, by golly, we've got to get better at looking at sugars and added sugars in anything we take in, especially kiddie foods. A lot of this stuff
mhm.
has between 20 and 35 grams of sugar. Can you imagine? I mean, they're wired up, and then we wonder why the kids have ADHD and ADD and can't pay attention because their body gets acclimated to having a high level of sugar all the time. And then you imagine when sugar levels normalize for them, it's like a sugar crash
Crash.
because they're always
Wow.
on a high on it. So sugar content, it's a big thing.
That is definitely. I think Dr. Song just came out with something. kind of teaching kids, how to look at the food labels. And
Right.
it's important in schools, and I'm not sure how much they go into that in school, but even in school, Pop-Tarts are considered a healthy breakfast,
Right.
in our public school system. We are so broken. The picture over here, it is just so much bigger than we can even start to understand this huge industry and the pharmaceutical
Yeah.
companies, everything that's involved in our children's health. And then the government gets
They get involved.
involved.
Yeah. And then a great person to follow, and that I learned on how to read labels, is Bobby Parrish of Flav City, and he kind of went through with me on what to look for on the labels, what to stay away from, and things like that. A really good education, good guy.
That is so good. It is a fight out there, because I remember when my daughter started a public school last year, and I would send like chicken and broccoli for her lunch, and the kids would go, "Ew, broccoli," and everybody has prepackaged food. There's so many issues with
Right.
that. The first one is that parents just do not have time right now.
Right.
We are
Right.
so
We
busy,
don't.
mom and dad working, and we're just trying to make it. We all
Right.
know that eating healthy and cooking food takes time. So that's one issue. And then we can't trust, unfortunately, the schools to provide healthy options. Sometimes they will have broccoli, but they have cheese all over it,
Right.
just certain things like this. And then of course the pressure that these kids are going through, everybody else is having it. Why is it wrong? Why can't I have it?
Right.
So it is a fight, a constant fight out there. But we've been teaching. I have an almost 7-year-old, so we've been teaching her, what are carbs, what are protein, and all these different food groups, and that she needs to try to get as many as she can in every meal. So she's been
Right.
asking a little bit more, and asking what kind of vitamins are in this. If I take this, I got her a blueberry because she didn't want to eat a blueberry and blackberry the other day. And one trick that I do, I usually put something that I know she really likes on a plate. And if it's something new for her to try, I will usually put one or two,
Right.
something very small that she kind of looks at it like, that's it? That's how you're going to put it on my plate? And I go, yes, that's all. And she said she didn't want to even try it. And I was like, well, do you want to know how many vitamins are in this little tiny fruit? So
A
we
lot.
have, exactly, we have
A
Alexa
lot.
that we use. So we asked Alexa, what are the vitamins in
Yeah.
blueberries and blackberries? And then, she just started naming all of this, and she just, wow, this is going to make
Yeah.
you faster. It's going to make you stronger. It's going to make you heal faster. So using different adjectives and different ways of explaining why it's important for them to eat that. It's not, you should eat that because it's good for you. Kids don't,
Yeah.
you
And
have
this
to kind of,
the same with kiwi. Kiwi is loaded with vitamin C on it. I just don't. I try to avoid strawberries from the kids
is
for the
that in
main
the
reason.
dirty?
Well, the pesticide stuff. Yeah. Yeah.
Mm-hmm.
And higher sugar content.
Yes,
Uh,
the dirty. I have to look up again the dirty dozen to see what's
mhm.
in the clean 15, I think it's called. You guys
Right.
correct me if I'm wrong. But it's so interesting what's out there. But it does start at home. We
Mhm.
all know it's difficult raising children and being so busy. But the more we introduce these things to them when they're young, the more likely they are to grow to their optimal, to
Mhm.
their full potential. Um, so as a clinician, we are overwhelmed by all of the different options for orthodontics out there. How do I know what is the best option for my patient? So as a myofunctional therapist, I am referring these patients when I'm seeing certain things. Can you talk to us a little bit about that?
Yeah, so there's all kinds of appliances, various names, and in my opinion, at the end of the day, they all do the same thing, expansion, right? Then there's two ways to expand, this way and this way, essentially, right? Now, the most of the expansion expand this way. Most people have difficulty expanding this way. Okay. Now, the key to success is this expansion here. So the front to back,
Hmm.
more so than the side to side. Now,
More than this.
yep. Now, having done and having used all of the expanders out there, in my opinion, it comes down to what is the level of the understanding of the doctor? What are they trying to accomplish? What is their comfort level? And what appliance works best in their hand? Okay. And the reason I say that is what works well in my hand might not work as well in your hands. That does not mean that we can get the same end result. Okay. Whatever appliance you're biased to is, maybe it just doesn't work for me. But using what I use, I can still get them to where I need to get them. That's the key.
Okay.
Now, I say this because one, I've used all the expanders. Two, I understand all of the expanders. And then three, not only do I have a solid understanding in the principles, science, and the mathology of the functional appliances, but also orthodontics, and then also surgical orthodontics, and then the orthopedic aspect of dental, because I treat TMJ problems. So the softer the bone, the more open the sutures, you essentially, at the end of the day, you can almost throw anything in there and expand them out. The key with kids is one, compliance is huge, and the difficulty for most practitioners is the level, compliance, right?
Yes.
So you have to be able to do what you want to do quickly, efficiently, because compliance will start high and start leveling out, and that that's what can make or break you. You don't want to be an expander in the mouth forever, because two things: not only does the compliance drop off, but then also you start creating other functional issues in the mouth, because we're not, you don't want to have that stuff in your mouth all the time. It creates other issues. From practitioner to practitioner, how long of a leash they keep for the patient is important also, and how frequently they're either seeing them or touching base with them is important.
That is amazing. So you would recommend a not removable expander for children? Would that be a little bit easier for them?
So I do on kids more removable, because one, their hygiene is never on point, right? So you want to have that function of being able to remove. Now, I also don't want my appliance to be loosey-goosey in the mouth either. Therefore, appliance design is important. And then the other important thing is you definitely don't want the appliance breaking mid-treatment, because one, you lose time, you lose faith, and the arches collapse on it. Most of us practitioners, we're not doing appliance fabrication in-house or anything like that. It's typically going through a lab on it. So using a lab for this type of stuff, that's kind of a specialty oriented, using quality solder welding, quality turn point screws and things like that is important, because you don't want things breaking while you're trying to rock and roll.
Perfect. We have a question from Jan. She says, hi, is there one appliance that offers more forward expansion over the others? Would this response vary by age, children versus adults?
Yes. So second part of the question, yeah, response varies by age, right? Now, forward expansion, how does it happen? Typically, like your sagittal, let's just call it a Schwartz appliance, right?
Okay.
The catenary wires that come across, then the activation of the sweep arms will help create that. Now, what we want to do, take those, pushback teeth, draw everything forward. Now, the component with proper forward expansion is very precise, very successful, very good myofunctional therapy. What I do for my myofunctional therapy is I get the teeth out of the way, the kids looking like Bucky Beaver headlamps, okay? And then guess what brings the teeth back? From the inside, the tongue; from the outside, the lips.
The lips.
Right? Now, the lips, we have to make sure there's no frenulum, ties creating any restriction. And then the equilibrium of that forward growth is created by, one, the lips on the labial, and then two, the tongue on the palatal, and that lines them up really well. But working without the use of myofunctional therapy in those cases becomes really tricky, because if they're a mouth open posture, you kick everything out like headlamps, good luck bringing those teeth back down. It becomes a challenge. Or you're marrying that case for a little longer than you want.
That is so interesting. Somebody else had a question. We're going to get to that adults in just a second.
The second part of the response, in adults, we do this via controlled arch. So what that means is, think of it as a fixed expander. Think of springs, open coil springs compressed in the premolar areas. And we're trying to basically stretch the maxilla, premaxilla segment forward. Now with that, we have to consider bony densities. Secondly, we consider thickness of the buccal plate of the bone, because if we ratchet it up too much, we don't want to, create, soft tissue resection issues, or apices of any of the teeth, into soft tissue issues, things like that. So it's got to be very carefully planned out. So all of these cases, normally, I'm planning looking at on a cone beam CT. So that way I have a good idea of what I'm getting into and how I'm going to approach it. So bone densities for me are important. Mouth posture, tongue posture, breathing is important in terms of how I'm going to tackle the case. And then also whether I'm going to do fixed appliances versus removable appliances and things like that.
Do you recommend myofunctional therapy with all of your cases, most of your cases?
All of them.
What is usually? Wow.
Yeah, they don't have an option
out there.
Yeah.
My goodness!
Yeah.
If everybody
And mainly because you got to remember, I run a specialty practice, so a lot of the cases that I see have had bicuspid extraction retraction that they're trying to reverse, or have gotten orthodontic consults where they've already heard it. Hey, you need to get your teeth taken out for whatever reason, or they're referred from the ENT for a breathing issue, and things like that.
Wow. And I did have this question, which we already talked a little bit about adults, but as an adult, I have a very high palate, a narrow bite, and a gummy smile. Especially with a gummy smile, do I have any options at this point?
So gummy smile. So one, we got to first figure out how much tooth that can be on full display is still under the gums. Okay. So we have to explore what are our non-surgical options. Can we do like a aesthetic, a gum lift? Now, a gum lift can go two ways. Just a gum lift where we're erasing some gums, or a combination of gum hard lift, where not only do we need to lift the gums, but we need to lift up the bone too, because if the bone's at a certain level, the gum's going to be at that level too. So sometimes it requires me, lifting up the bone, so then the gums can, put the gums in the right spot, and then taking care of it that way. Now, in extreme situations, I do orthognatic. surgery related stuff to reposition in a proper manner on it. So those are kind of the options there. Now the orthognathics would be more in an extreme type of case.
Do you usually do surgical expansion before orthognatic surgery?
Yes. So, we have to level and align the arches before orthognathics. And then in terms of orthognathics, I do a lot of the surgically assisted rapid palatal expansion, and then also Lafort 1, Lafort 2, true orthognathic surgeries. Yeah. So yes, we have to get the teeth out of the way. The way I explain it to patients is, if I'm going to do orthognathic surgery, which in essence is I'm dismangling the upper jaw, lower jaw, and I've got to be able to cut somewhere, and therefore I'm going to do reverse orthodontics to move teeth out of the way based on where I'm going to make my surgical cuts. Because when I'm cutting, I don't want to cut through your teeth and create tooth damage, because then whoever's restoring the case, it complicates it significantly for them. So we don't want to damage any teeth while we're doing orthognathic surgery. So therefore the cases are prepped for that.
Awesome. I do want you to touch base a little bit more on the options for surgical expansion. What do we have out there and how do they work? Do you still do myofunctional therapy while you're in the appliance? Or
yeah,
do you wait?
So for the surgical cases where a rapid palatal expander is essentially what we call screwed into the palate or fixated into the palate, in terms of size and shape, these things come in all different size, shape, and forms. So the period of time in which we're doing the expansion, it's kind of difficult to do the myofunctional therapy component because typically I've got stuff in the mouth. So we do myofunctional component before and immediately after. So as I'm on the surgically assisted, we're ratcheting up pretty quickly on that. So my gadgets are not in the mouth for a significantly long period of time. So once that gadgetry is out, then we start with aggressive tongue exercises, okay? And the reason for the tongue exercise, you got to remember, in a lot of these cases, I blow them open, 6 millimeter gap between the two front teeth on it. So you got to, if a 6 millimeters gap showing between 8 and 9, you can just imagine what's happening in the palate. You can probably throw a football through there. So we need to be able to maintain that without collapse. So one, we want tongue posture and help the tongue, and then two, obviously on the teeth, I'll either have brackets or like a clear tray to hold that expansion also, or a TPA arch.
What is the average time usually? You said it's not long, but what is the average time that you do the surgical portion?
About 3 months.
Awesome. That's amazing.
Yeah, 3 to 4 months.
And what is the time needed for a patient? So let's say that somebody lives out of state and they want to come see you for surgical expansion. How often do they have to see you within those 3 months?
So surgery, they'll see me typically once a month. And a lot of that is virtual.
Oh, amazing. Because we know that there's not many options in the country, and people might live in an area like me that doesn't, you don't have anybody that does it. So it's important for adults to understand the time commitment if they choose somebody to go see somebody that's out of state.
Right. And the other thing we consider on these cases is, I know like in the airway world right now, everybody wants to expand and things like that, but I feel like it's getting a little closed-minded in a sense that we're getting so deep into the airway, we're not stepping back and looking at the whole picture. And what I mean by that is sometimes our structure is our structure, and when we alter it, we have to see, hey, what are going to be the side effects? Okay, so if I go through expansion, what issues may I potentially create or harm in virtue of trying to get expansion here? So we need, we got to get better at looking at those things, and also, respecting that, and then making educated decision on it, especially because we're connected individuals, right? So when there's jaw issues, there's going to be upper cervical neck issues. As the lower jaw recedes back, is pure physics. When something goes back, something has to go forward. So if the lower jaw goes back, it's our neck that's coming forward, right? And then that usually also has impact on our joints up here. So we got to look at, we got to get better at looking at the whole picture when we're thinking about doing these cases, planning these cases. And that's why I hope, the annual meetings where we can go back in live events will come back.
Yeah, definitely. Since you touched on the subject, will you talk a little bit about the TMJ and how our joint is affected by malocclusion?
So the biggest thing is, as same thing, narrow jaws, narrow arches, steep plane of occlusion. So if we don't grow horizontally in a horizontal manner and we grow vertical, the maxilla or the upper jaw starts dropping down. Okay. The reason the upper jaw drops down is because the tongue is not holding it up. So the tongue allows, keeps it in place in regards to the vertical growth of the face. So ideally, if the tongue is in proper posture, proper tonus, proper position, we get increased horizontal growth of the face, more symmetrical, more balanced. If that doesn't happen, our arches, jaws, face kind of grows in a vertical manner. In a vertical manner, growth that the cant of the upper jaw, the maxilla, starts dropping down. As the cant of the upper jaw drops down, the lower jaw also drops down and back. As the lower jaw drops down and back, you got to remember our joint is at the distal terminal end of the mandible. It's all connected, so that's getting shoved back further in. Along with narrow arches, crowded dentition, infraocclusion, teeth wear unevenly because of the crowding. As the teeth wear unevenly, you got to remember there's changes in 6 planes of dimension. Pitch, roll, yaw, up, down, side, front, back. Got it? So that cumulative effect then, compresses the joints more than it should. Now imagine this, you have a ball in a socket of a joint, hypothetically. You push the ball further back in the joint, and if you have a cartilage in the middle, where's the only way that cartilage is going to go? It's going to squirt out somewhere. And typically with our jaw joints, it's going to be more forward in these type of situations, right? That compression leads to breakdown of the vital structures, the cartilage that's in the joint compartment. You give it the effect of time, in the cumulative effect of time, wear, tear, use, and abuse, and it ultimately leads to a dysfunctional joint. That leads to the clicking and popping that you either hear, and a lot of times is benign where you don't hear it, but it's still happening because the joint just hasn't gotten trashed enough yet, or broken down enough.
Wow.
So what we do in the joint therapies is we recreate a person's head in virtual reality, so we can see which way the joints are going. Because you got to remember, you have 2 joints and they don't wear equally on either side. It's kind of like when you have a set of tires on a car. None of the tires wear equally. Same thing in our joint. It doesn't wear equally. Therefore, if you think about it, you put a mouthpiece in the mouth that's not fabricated. And what I mean by that is you take a mold and you send it to a lab and they drop ship you something with zero understanding of joints. What do you think is going to happen? It may unload one joint and may distort or further compress the other. On low-level cases, it will fix them, but on a true TMD pain patient, it very well kind of makes them worse, you know? So in virtue of using instrumentation to allow you to build the appliance, because in virtue of using instrumentation, we can objectively reposition both joints in a concentric position and capture disc where we want it to, and then fill in the space with mouthpiece material that looks like teeth and strikes like teeth. That, in essence, will help neutralize the compression in the joints to help get the case kind of pain-free.
Wow. That is unbelievable. Amazing. That was going to be my next question about these nighttime bruxism appliances. Is there a time that it's still recommended?
Yeah, so, the nighttime appliance, if a person has good, healthy, normal joints, then in essence, you can put any mandibular appliance in the mouth, like whether it's a full coverage, a soft splint, or a soft rigid, or a full coverage lower flat plane type of stuff, right? And then if a person has acute issues of frontal headaches, then something like an NTI works really well. Long-term use of NTI, obviously we're going to get other issues, other baggage that comes with it. So, but used properly for an acute short-term on a frontal situation, NTI does a job. On a bruxism patient, a lower soft, something like that works well. I'm a bigger proponent of lower appliances as opposed to upper, because if you think about it, the lower jaw is what moves, not the upper jaw. So you want the appliance in the lower. On the significant TMJ cases, then you need a true neuromuscular orthotic that's well calibrated. So those are kind of the options out there.
Very interesting. I want to go back a little bit and talk about little kids. I just remember that I have a good friend in Brazil who's a pediatric dentist and orthodontist. And she sent me a study talking about expansion in little ones and how you should attach them on baby teeth, because the amount of buccal bone that you would lose is much, much less than attaching them to the permanent teeth. Does anybody even do that? Because I know people are so scared to work with little ones.
No, I attach on baby teeth.
You do?
On it, the expanders and stuff. And the reason for that is as we're creating expansion, we're also creating a level of neurostimulation, and a level of bony growth and things like that. Okay, so that allows for growth of the bony plates. And then you got to remember, a lot of times the 6-year molars will not be in, right? So if the 6-year molars aren't in, and you're a practitioner that comes off the 6-year molars, what are you going to attach to? Or how are you going to do the case? You can't. So to give you versatility, you have to come off the baby teeth. Now, still in those situations where we only have A through J, K through T, I prefer, in my hands at least, a removable fixed, a removable, for me, works better, where I can get, it gives the patient the sense of cleansability. So the parent can take it out, brush it, clean it up really good, put it back in. And a lot of times I'm having the kids take it out when they eat.
Mm-hmm.
only because of, I went through this stuff with my kids. I expended my kids. And prior to me treating my kids, I was having the kids wear it while they eat too. I realized quickly, and it's disgusting. So what I have them do now is eat whatever and then rinse your mouth out, put it back in. And I haven't had any issues.
What is the name of this appliance that's removable? Is there a specific
I
name that an orthodontist would know?
So I train with Hang amongst many others. So a lot of my designs are Hang expanders. So I think it's almost synonymous, and a lot of a lot of people will argue about it to like BioBlocks and Crozats and
Mm-hmm.
things like that. Everybody puts a name to something for money.
Mm-hmm.
Uh, and for me, when I educate people, I tell them, listen, figure out what works well for you and in your practice, in your situation, whatever, and run with it and become the master of it.
Awesome.
You know,
Amazing. I
because
love
it's
that
not
advice.
just one thing. You want the thing to stick.
Jamie had a question earlier. She said, can you still get expansion on a post-pubescent 14-and-a-half-year-old female with an RPE? That might be the only option in my area.
Yeah. Yeah. So 14 and a half year old, I would start with like a hang expander, BioBlock type design. I would start with that first. Okay. Regardless of what the arch looks like, and just kind of open up as much as I can get. I would obviously, uh, you know, is it Jamie Genson? And feel free to reach out to me or email me if you want help on these cases or whatever. I'd be fine and more than happy to help you. Take a cone beam. Let's see what you're working with, um, and then based on cone beam, as long as joints are healthy and there's no functional click issues, functional joint issues, then uh, get get an expander that you're comfortable with in there to start moving teeth out of the way. Now, if you're talking about a surgical RPE here, those are possibilities also. But a 15 year old, I don't think you'll be having to go through surgical options.
Awesome. So you still recommend an RPE for young kids? Do you use
Yeah,
them at all? Okay, awesome. Harini has a question. If there's an even joint, does this cause asymmetry? Or if the tongue is not positioned properly in the upper maxilla, does this cause asymmetry?
yes. So if there's uneven joints, yes, it's going to cause a level of asymmetry. If the tongue's not positioned, I'm not convinced that. And if the tongue does, it's probably a very, very small percentage. Usually asymmetry is structural issues. It comes from structural issues and not from soft issues. Okay. And what I mean by soft issues is we're not going to get maxillary asymmetry by virtue of tongue. There's a lot of things that happen before that, before we can kind of blame the tongue. I've seen a lot of it where it's genetic type of stuff, or I've seen instances where it was a forceps vaginal difficult delivery situation uh, that has caused issues, and then obviously joint issues where there's unilateral mandibular hypoplasia or a condylar a size length discrepancy issue, which happens more frequently than you think. That it comes with that also. So hopefully that makes sense.
Definitely. And in the myofunctional therapy world, we're always looking at asymmetry, and a great way to look at it is I usually do the measurement from the corner of the eye to the corner of the lip, and whichever is closer, I think mine, this
Mhm.
one's closer, that means that the patient chews more on this side. So of course we always encourage a little bit more on the other side. So and you can, check the buccinators and the masseter strength and see which one
Right,
is working more. So a little bit of asymmetry you will get from chewing on one side, and most
right.
of us have a preferred side of chewing. So pay attention to that. Where are you chewing? How are you chewing?
Yep.
And I
And
usually
that's
say,
that's a function. That's a function of growth stimulation. Because
mhm.
if you're chewing on strictly one side, then you're only working out one side of the muscles. It's like you're just doing bicep curls on one side and not the other. This creates a
What's going to
distortion.
happen to the bone?
Right.
Exactly.
Now, when you're doing this measurement, I also want you to look at measurement here on it. So ramus angle here to the joint,
Okay.
and
I agree.
that'll coincide with these also.
Ah,
To give you a better idea of where we're getting more stimulation as opposed to the other, right? So that will also help with, hey, is this a genetic DNA condition creating a unilateral hypoplasia type of issue, or is it a social feature of chewing on just unilateral chewing, and so there's only growth stimulation on one side as opposed to the other.
that is.
Right? So, in a lot of that, especially on these kids like with unilateral chewing, if we can get that corrected early on, can you imagine that's you just saved orthodontic surgery because there's no way, no other way to fix that.
That is so true. Oh my goodness. Guys, do y'all have any last questions? Please post them for us. If anybody would like to get in touch with you, should they go to your website, email? Let us know.
Yeah, so the website is depeshsitaram.com or columbusdentalsolutions.com. My email is my first and last name at gmail.com. So depeshsitaram@gmail.com.
Awesome.
Yeah, so that'll
Uh,
be good. And then we're at the end of the year, we're hosting a live event in Miami, educating on, you've burned through all of the non-surgical options for treating TMJ airway, but you
mhm.
don't know what to do next. You're out of options. Okay. Now you know your only option is surgery, but you don't know where to go, who to talk to, how to set it up, and all of that kind of stuff. So what I'm taking the initiative of doing is uh, teaching a course on how to diagnose and set up cases after you've been through the myofunctional component, the all of the fascial releases, the acupunctures, the massage therapies, the orthotics, all the dental stuff, but the facial pain, the joint pain is just not going away. What are the next options?
Mhm.
How do you treat it? A lot, most people kind of or don't know where to go for that. So we're setting up like a lecture series.
Do
Uh,
you have dates yet?
the September 17th weekend.
That is amazing.
Uh,
So is that right before the AAPMD in Atlanta?
That is, yeah, the APND is either weekend after. Yeah, I believe the APMD is the week after. Because
Awesome.
from Miami, I'm going to Atlanta.
Great.
Uh,
Airway Circle will be there.
yeah, Atlanta will be fun. I'm glad they're keeping that event. It's a good group. There's a lot of great learning. I hope the turnout is good this year. I think it will be, and I think it's great for hygienists, aspiring myofunctional therapists, because we need more
Mhm.
in every part of the country to create education, in the communities, to teach other hygienists who are unable to leave their practices or work in maybe a corporate setting, so they're not privy to a lot of this, CE stuff and or whatever the issue may be, right? So hopefully we can start kind of I call it grassroots efforts, and percolating the knowledge on what to look for, how to treat, the directions, and then also to push the doctors that the all you guys work with, to
Hmm.
push them to dig deeper, to seek knowledge further in education, and to be able to do more to treat these patients, because it's a rampant problem everywhere.
Hmm.
You know, and I think the Brazilian, you mentioned the Brazilians. I think the orthodontic work in Brazil is far ahead of the United States. They're more, you know, they're heavily in the research and cutting edge type of stuff. I feel like as compared to what we're doing,
Hmm.
either. So I think we need to really think about pushing the envelope, because there's other ways to do things, right? Yes,
Definitely.
bicuspid extraction, retraction, whatever. It served us well, but we need to look at other options, and what's whether it's right or wrong. Uh, I feel like we need to treat
And
people.
we evolve. I mean, we are constantly learning. The
Right.
first treatment for sleep apnea was a tracheotomy. I mean, he worked
Yeah.
100% of the cases got better,
Right.
but are we gonna keep doing that? No, we need to keep
Exactly,
doing
and that's
research.
and that's exactly we with the small jaws at that point in time. The only way to treat, you take a few teeth out to fit them in the small jaws. I get it, that's fine. But now we know how to grow jaws, and if we
Hmm.
grow the jaws a bit and allow for all the teeth to shake out, don't you think that's a little bit better of an option? You know,
Definitely. I was
so just
watching
looking at
two Brazilian orthodontists on a live on Instagram the other day, and they were talking about showing tons of cases of the mini implants that they put right here to be able to.
yeah.
So they're moving everything and growing everything by using the mini implants. And is there a lot of people doing that here yet?
So my partner, Hamid Nasri in Miami, so he's been getting a lot of training with some Brazilian orthodontists. So he's been doing a lot of that. I'm going to be, I spend a little time down there with him also. So I'm going to kind of get an idea of what he's doing and how he's doing it. And for us, it's all part of research, because we run the TMJ Research Foundation. So
Oh,
all of the
amazing.
cases we do are research and education cases.
Wow. Tell us more about the foundation. How can people learn more about
So
it?
yeah, so the Team Day Research Foundation is for the purpose of education, uh, and learning. So as I got more and more away from general dentistry and into more specialized TMJ stuff, it just kind of evolved naturally to uh, be able to retrospectively look at all of my historical cases, and see the cases post 3 years, post 5 years, post 6, 7, 8 years, to see how they advance along. So that way I can kind of correct my habits now in the present, and how I'm treating cases now, and allows me to see, hey, how did I do that case? What could I have done differently? What were the patient's habits past, 5 years post me treating them? How did their habits change? And because now I know this is like the American habit, how can I modify my treatment methods to fit into the American habit? Uh, Also, right? Because
Definitely.
the other thing we're fighting is, they're compliant while we're providing them active therapy. How much of that drops out once we get them out of active therapy? Right. So for how long do they keep taping at night? You know, or for how long do they keep doing proper sleep hygiene? Right. So that
Exactly.
long-term compliance, is what we're wanting to see.
We do encounter that a lot, unfortunately. It is difficult implementing all these extra things in people's already busy lives. But a lot of the myofunctional therapy goals, and a lot of our concept, you do have to kind of do a lifestyle change,
Right.
like nasal hygiene. When should I? Every night, everybody should be doing nasal hygiene every single night for the rest of their lives.
Yeah.
Or nasal clearing. That's even better than nasal hygiene when you actually get a lot of that saline either
Right.
through the nostril or you swallow it, whatever, however you want to do it. But keeping your nasal passages, your airway clear and clean is really going to reduce the risk of you getting any upper respiratory infections and all of that. And then you can breathe better and you can grow better if you're breathing through your
Right.
nose. It's a snowball effect.
Right.
I did have one last question before we
Sure.
go that I wrote down from earlier. With any of your cases, do you recommend body work ever? Any type of body work, physical therapy or chiropractic care
So case by
or,
case, yes. I use combination of chiropractics, physical therapy,
or
and
craniosacral?
yeah, craniosacral and body work. And what I mean by body work is creating mobility and fluidity of fascia. Okay, so fascia, when that is dense, creates tightness and irregular pull in not only tendons and ligaments, but also musculature. And then when muscles torque, then the muscular system kind of contorts. And then muscles, you got to remember, insert and attach from a bone to a bone. So it creates stress and strain on that too. So depending on what level of care that they need, then I set them up with the proper people. So if that means if there's if there's not mobility in the upper cervical neck, then I set them up with the proper chiropractic care to establish mobility there. Now, when I have immobility or restrictions in the upper cervical neck, typically I'm going to see hip and pelvis canting issues. So with that, I set him up with my PT who specializes in pelvic floor relapse. So a lot of my female patients, I set up with pelvic floor, stuff also. The reason being is, if they've had a child via C-section,
Mhm.
there's usually a significant amount of connective tissue scarring and therefore the density that comes with that. So we
Uh-oh.
set them up with the girls to help create, remove those constrictions. In regards to the pelvic floor, a lot of times when there's nerve pain shooting down, and or floor canting, and therefore concomitant hip canting, that affects directly posture and alignment, and then it creates irregular pain pattern and things like that. So yes, we have to. And in my world, everything's kind of connected. So and we you even have to look at gait, the postural gait analysis of how a person's walking, right? So and if we can catch this one leg shorter than the other leg issue early on, then you can set these kids up with the right person to get that corrected, and you're going to save them the millions of dollars, down the road with stuff. So yes, we're working with somebody on pretty much every case.
It is so important for us to start looking at the patient as a whole. Like you said, everything is connected, and building your multidisciplinary team is so
Right.
important. We can't do all these things by ourselves, but with an amazing team, we can really help our patients become healthier and live a better life, thrive with
Yeah. And people ask me all the time is there's nobody in my area, or the chiropractor doesn't want to talk to me, or whatever. And you just keep knocking on the same door. At some point they'll start listening to you, and you get to a point where you know what you're talking about. They're going to listen to you.
Definitely. You just got to keep trying. I'm pretty
Right.
persistent.
Yes.
Oh, goodness.
Yeah.
We're building our team over here in Savannah. It's slow, but it's going.
Yeah, there's some great guys. There's a lot of good people in Savannah.
Introduce them
For,
to me.
yeah.
Anyways, guys, this has been an amazing hour on a Friday afternoon. Dr. Depeche, thank you so, so much for being here, taking time out of your busy day, busy schedule to enlighten all of us with
Yeah.
so much amazing knowledge, amazing information. And I do ask everybody, please share this live, share in your personal page, in your professional page. The more people that we can reach with this information, the more professionals that learn and listen, the more people and patients we're going to be able to reach and help. Next week with Clubhouse, we have on Thursday how to read a sleep study. And you guys are going to find out who our speaker is on Thursday morning. And then on Friday, we have functional airway management. If you guys want to guess who that speaker is, it is somebody that I cannot even believe that we got in contact with. We're super, super excited to have this person on Friday also. So send me a DM if you guys want to guess for a free prize. Also, if you have not joined our Clubhouse Airway Circle Club, I can send you a link, or I think we have a link in our bio on Instagram. Please join. Our club is growing so much. We had an amazing talk last night. We had a sleep physician show up and really help us and give us, so much information on his side. So it's been super fun and super good, and people are learning so much. We're all learning together. We're all over here, to keep learning and teaching each other. Somebody asked about a study concerning chewing side of facial symmetry. Send me a personal message and I'll send that information to you. It says Facebook user, so I'm not sure who it is. But this is it. We are done. Thank you so much. Thanks for coming. Have a safe trip. Do you have any last words of goodbye?
No. Thanks for having me on the show. It was good. Anybody who has questions, feel free to reach out to me. I'll be more than happy to help.
All right. If you guys go on Airway Circle group, I'm going to make sure that I post Dr. Depesh's information there about your course coming up, how to sign up, and his website so you can get in touch with him. Okay.
Perfect.
Thank you,
Thank
guys.
you.
Have a wonderful day. Bye bye. Happy weekend. Happy Memorial Day.